Okay, so this is the respiratory station for those nurses who might be helping with in our departments between the 3 campuses. Some of the devices you've seen before, but I'm going to go over a short little scenario with each anyway. Everybody's seen the venting mask. It has all these pieces and it's tubing. On the bottom of each one, there's the different FiO2 and then the liter flow. The blue one is the easiest to see. On the orange one, it's one of the hardest. Each one has a different flow. But for the most part, we use the venting mask to make pieces to do a trach collar for when they need to do a mobility walk with PT, or if they're going on a transport down to X-ray, cath lab, CAT scan, or whatever. So you would take this part would normally be to a tubing that would be white in color to the aerosol. You just take it off, put the piece of the venting mask to the trach collar, and then this would go to your tank, and then the appropriate liter flow, again, from the bottom of the colored Venturi adapter. The next oxygen device that we're using a lot is the high flow cannula. It can be determined better from the emerald green color compared to the regular green, which would be similar to this tubing of the regular cannula. 1 to 15 liters. For the flow on this. Regular cannulas are 1 to 6. Either one can use a bubbler from 4 liters or higher. That's our policy. So if you have somebody on 4 liters or more, please get them a bubbler. We are using these quite often now to intubate the COVID patients. We're pre-oxygenating with these instead of using the ambu bag. We don't want to disperse all that aerosol into the air. So you're going to be seeing a lot of these on the floors. Non-rebreather, everybody has seen and used them. A lot of people don't always necessarily know how to set them up properly. So it has the 2 valves on the side and then the valve in the bottom by the mask. When you first go to put it on between 10 and 15 liters, hold the valve down to inflate the bag, and then once that's inflated, go ahead and put it on the patient's face, but removing one of the valves. Make sure you always remove one of those outside valves, because if you don't and the device were to fail, it could kill the patient because they would be rebreathing their CO2, because these valves, when you breathe in, suck against the mask, and you only have this to rebreathe from. If the bag is on their face and the bag is collapsing in any way, you want to turn up the flow. That means that they're not getting enough flow. So if it's at 10, turn it to 15. And if it's at 15, you can always turn it above the 15 is what we call flush. And so it would make a lot of noise, but it's definitely going to give them some more flow. Theoretically, it's about 30 to 40 liters. Okay, the next device that some patients are still getting are nebs. So in the packaging would be all these things in plastic. The face mask is separate. If we do have to give a neb, they are to be on a non-COVID patient, and that's basically it. 8 liters to run. There's several different meds that we give. Duoneb is in this packaging. It just depends which one pharmacy sends us. Purple and the blue. Ampules come out looking like this. The albuterol are the pink or the blue. The pink ones, if they give it, you can still give it, but it's only going to be this small little ampule. You'll have to add 3 cc's of saline to the package, to the neb cup, in order to give it. Otherwise, the ampule that comes out of the blue tubing will look like this. It's a 3 cc. It's still the same dose of albuterol, the 2.5 milligrams, but just different solution forms. This one, the orange and blue, is Pulmicort. Pulmicort is a steroid. It is given after the albuterol or Duoneb nebulizer, and if it is given, it's also given in a separate neb cup. So the reason for that is because once you give the two together, it kind of forms a crystalloid solution. So years ago, we used to give them all the time that way, but pharmacy changed that. So now it's 2 separate cups. And because it's a steroid, anytime you give this, you have to have the patient rinse and spit afterwards. Okay, speaking of some of the steroids. So Brio is one of the most common inhalers we give. Most of the Ellipta inhalers look like this. it counts down. This one was initially at 30, and then when it got to number 9, it started turning red. You open it up, it clicks. That means it's ready for the patient to use. They're going to be hopefully sitting up the best that they can, upright position. They're going to put their mouth on the inhaler, kind of looks like little fish lips. They're going to take a breath in to actuate the puff, and then just have them breathe in. A lot of times it doesn't make a noise, they don't feel it or taste it, but they can usually tell that they did it. These are usually in the nurse's station. They're not from respiratory. There's several different ones. I have pictures of this. So the neuro is the red one. We don't use this that often, but if we do, it's not a steroid. So it's similar to Combivent, or it's similar to a Duoneb, but in inhaler form. It starts off at 30 and it counts down. Brio is the one that we use the most here. It's a mixed inhaler. It has 2 medicines in it, one of them being a similar medicine to albuterol and then a steroid. So they will have to rinse and spit after this. Our Nurity Ellipta has 1 med in it. It is also a steroid. It's an orange colored inhaler. They will have to rinse after this one. Incruise is 1 med, but it's similar to Spiriva, so it is not an inhaler, so there is no rinsing needed. Another long-acting bronchodilator medicine that we give through a neb is called Brovana. It is a refrigerated med, so it would be given to the nurses to put in the refrigerator on the floor. That is given third in a sequence of 3 nebulizers if it is ordered. Mucomist is one of the last meds that we normally give. It's a mucolytic. We mix it with albuterol or the Duoneb, whichever bronchodilator is ordered, and it must be given with a bronchodilator at all times, because if it's not, it can induce wheezing, and we definitely don't want that for some of these patients. Another medicine that's been frequently being ordered that is on the floors is tobramycin. It's an antibiotic that again would also be found in the nurse's station. Okay, so the other inhalers we have are what I like to call the old school inhalers. So they look the general way that we used to seeing them. All of our inhalers that look like this have to be given with a spacer. It's been our policy for years. We're going to shake up the inhaler. If it's the first time the patient's using it, we have to prime the inhaler, and what that means is we're going to shake it, face it away from ourselves or the patient, and puff it. That gets it ready to have it in the chamber. It goes in the back of the spacer. There's not really a right or wrong way, it just fits in the back. Take the cap off. There's a one-way valve in there that the patient's going to use, and they're going to breathe in. So what I always tell a patient is have them sit up the best that they can. They're going to blow out into the air. Then they're going to put this in their mouth, and as they start to breathe in, then they're going to puff it. And then as they're going to continue to breathe in and then use a breath hold. So it's a blow out, start to breathe in, puff it, still breathing in, and then a hold. If it's albuterol, they're going to do 2 puffs of that. They're going to wait a minute in between each puff. And then if they have a secondary inhaler, whether it be Pulmicort, Symbicort, or anything else, they're going to wait 2 to 5 minutes before they do that inhaler. And then if they have that steroid inhaler, they're going to rinse and spit afterwards too. If the patient is somewhat unable to rinse and spit after a nebulizer, steroid nebulizer treatment, we're going to have them we'll wipe off their face a little bit, wipe off the mask, because we just don't want the residue from that inhaler or that steroid nebulizer inside of it. We don't want anybody getting thrush. Okay, one of the next ones we have is our incentive. The packaging comes with the little handout, and on this handout it shows male, female, and then it shows the ages, and then it shows a height going across. So I kind of went down between my age, and then I'm 5'6", I follow it down. About 2,500 is where my goal would be. So I set it to 2,500 on the spirometer, and then I always tell the patient to ignore the part right here where it says try to keep in between these arrows. And the reason I tell them that is because a lot of patients get very frustrated when they cannot keep this little device in between the arrows. I tell them just focus on the goal, and I even explain to them that a lot of times they might not even get to that goal, and just to kind of focus on a slow, deep breath in. 9 times out of 10, even though we tell them it's a giant straw, we're gonna suck in, their first inclination is to blow into the device. So if they do that, just repeat to them, it's a straw, we're sucking in. Have them do 10 goals, and goals is just breaths. And I usually tell them to do 4 to 5 times a day. Doctors will order it Q1 or Q2, but that's a little too often for a lot of patients because a lot of them have therapy and everything like that. So 4 to 5 times, usually before or after breakfast, after lunch, after dinner, and before they go to bed is usually good. When they're sitting there watching TV, they can do it during commercials. If they ask why, we just tell them that it's kind of to help prevent pneumonia, because if we tell them to prevent atelectasis, they don't know what we mean by that. But everybody's heard of pneumonia, so that usually gets them to wanting to do it. Okay, our last little device, the Aerobica, is our flutter device. We switched from what we used to use a couple years ago. It was called the Acapella. This is called the Aerobica. When it comes out of the packaging, it's at number 3, and then if it's the first time the patient's using it, and if they're an elderly patient, we might have them just turn it to number 1, so it's the easiest for them to do. What this device helps them do is to clear secretions from the airway. So a lot of times they'll have neb treatments already ordered, so after the neb treatment, while their lungs are nice and dilated, we'll have them breathe through this. For the COPD patients, we have them do a modified breathing technique sometimes, depending on how well they do, and it's just normal breathing through the device, and it looks like this. Just normal breathing, and when you breathe through it, it makes a noise that sounds like vibrations, and that's basically what they're feeling in their chest. For a normal patient who's younger, may not have too many problems with their lungs, the technique is a little bit different, and it looks like this. So they're going to take a big breath in and blow out through that, and they're going to feel the vibrations as well, but it's going to be much stronger in their chest than just a normal breathing. And that was a little easy for me, so I would probably turn it up if I really needed it to. But you're supposed to do this several times, like 10 to 20 times if you read the book. Not very realistic. We usually have them do 10. 20 times would be a little bit much. You're going to get a little lightheaded, but you also have them cough after each technique too. Some patients, especially the COPD patients, this can induce bronchospasm, so you just kind of have to watch how well your patient can do this. Most doctors will order this for their COPD patients, the ones who are kind of bedbound and just sitting there. That's it.